Hi, my name is Mary Schneeberger, and I'm going to be a junior at Notre Dame Cathedral Latin High School in Chardon. I am in the respiratory therapy department at Hillcrest Hospital, and the title of my research project is, Does hyperoxic therapy enhance the resolution of pneumothorax in the neonate? What is spontaneous pneumothorax? Pneumothorax is a collection of air and gas that surrounds the lungs, and this causes the lungs to collapse. This can occur in anyone, but especially if it occurs in neonates, it can be fatal if not taken care of quickly. There are two different types of treatments to cure pneumothorax. The first is hyperoxic therapy. This is defined as giving the child 100% oxygen. The second is conventional therapy, and this is giving the child just enough oxygen so they can maintain a pulse oximetry reading greater than 92%. It is said, though, that hyperoxic therapy may have a negative effect on the neonate due to presence of oxygen-free radicals. The hypothesis of our project was hyperoxic therapy in premature neonates with small to moderate pneumothorax reduces both length of stay and time to first feed. Records of 83 neonates were reviewed in Hillcrest Hospital's medical records using the ICD-9 open pneumothorax code of V3000 and V3001. What this did was pull out all of the babies in Hillcrest out of all of the charts. The secondary diagnosis code 770.2 pulled out all of the babies with pneumothorax from those charts. Only infant charts from the years 2008, 2009, 2010, and 2011 were reviewed that met the inclusion criteria. Inclusion criteria were small to moderate pneumothoraces treated with oxygen for a time period greater than 6 hours. The neonates meeting this criteria were divided into two different groups, the first, the hyperoxic therapy group, and the second, the conventional oxygen therapy group. Exclusion criteria were tension pneumothoraces or large pneumothoraces that required intervention from the beginning of the course. Something like this would be needle aspiration. The second was neonates who were transferred due to incomplete medical records because we couldn't track their oxygen levels. Third was gestational age less than 35 weeks, and fourth was expired neonates. Definition of onset of pneumothorax was based on physical exam findings, and the resolution of the pneumothorax was based on clinical improvement coinciding with time of first feed. The statistical analysis included a student t-test. Descriptive statistics of the population was mostly made up of Caucasian, but as you can see, there were several others such as African American, Asian, and mode of delivery was pretty much equal, vaginally and cesarean. The gender mostly made up of males, and then the initial delivery room mode of therapy was pretty even also, and there was also many who just had room air. Gestational age was split up into three groups, mostly falling in between 39.1 to 42.43 weeks. The range of the birth weights was from 2.256 to 4.462 kilograms, with a median of 3.328 kilograms. The length of stay and total therapy time for the hyperoxic group ranged from 2 to 9 days, with a median of 4, and then if you look over at the conventional group, Group 2, that range was also 2 to 9 weeks with a median of 4. The total therapy time was 2 to 127, and a median of 20.75 for the hyperoxic therapy group, and the total therapy time in hours was 0 to 83.5, with a median of 3 for the conventional group. As you can see, the range for the length of stay of the days was equal, and what we were trying to prove was that hyperoxic therapy was much larger than conventional. So this slide is definitely significant. We were also trying to prove that the total therapy time was much less for the hyperoxic therapy group, but as you can see in comparing these two charts, it was much larger for hyperoxic therapy. Also, time to PO feeds, as you can see in both groups, was also a very similar range with the same exact median. The results were patients in Group 1, which was hyperoxic therapy, received a longer exposure to oxygen hours when compared to Group 2, conventional therapy. The data is statistically significant when considering Group 1 versus Group 2. The length of stay and the time to first feed were similar in both groups. The data is not statistically significant between Groups 1 and Group 2. Conclusions: in this study, hyperoxic therapy in premature neonates with small to moderate pneumothorax did not reduce length of stay and did not improve time to first feed. The efficacy of hyperoxic therapy in the treatment of small to moderate pneumothorax in neonates is questioned. Recommendations: due to the small sample size, definite conclusions should not be drawn, and a larger sample size is needed to determine whether the preliminary observations are statistically significant. This is an ongoing study, and further trials are necessary to provide more data. In cognizance of external factors that may contribute to improved patient outcome, such as feeding regimen, is warranted. I would like to give a special thank you to my mentors, Dan Sutton and Susan Brandt, also the NICU staff at Hillcrest Hospital, Nadja Starling and the Office of Civic Initiatives, and my peer mentors, Melanie Rosenberg and Sarah Shripra. Thank you.